Hello, everyone. Welcome to another special VMR. We are super excited to have you all here. And today will be a pulmonary and critical care medicine. We have three guests here. I will start introducing the Dr. Gabby. Gabby Liu is currently an instructor of medicine at Northwestern University in the Division of Pulmonary and Critical Care Medicine. Her clinical focus is in interstitial lung disease, and her research focus is in respiratory epidemiology and using large-scale cohort studies to understand transitions from respiratory health to chronic lung disease. So, Gabby, welcome to the VMR. And if you want to say a few words, and we like to ask, what do you like to do outside of medicine?
Cool. Yeah. Thanks everybody for inviting me. Thanks to the CPS team for inviting me. I'm super excited to be here. So things I like to do outside of medicine. Well, I have two cats that I'm very obsessed with. So I spend a lot of time just like telling them how much I love them. I also like listening to like live music, going to shows, enjoy riding my bike, doing outdoorsy kind of stuff, hiking and things like that, swimming. So yeah.
Oh, thank you very much. And we have Amy Ludwig. She's raising the third year of Pulmonary and Critical Care Fellow and Chief Fellow in the Northwestern University. She completed her MedPads residency in the University of Michigan, and her research focus is in respiratory epidemiology with focus on recovery of viral illness and young adults. So welcome, Amy. And yeah, if you want to say a few words and tell us what you like to do outside of medicine.
Of course. Thank you all for having me here. It's so nice to see everybody. And thank you, Gabby, for picking me to be your fellow discussant. I absolutely love the city of Chicago, which is where Northwestern is. I love the restaurants. There's so many new places to try. I can't get through them all. So I really like to eat and I like to cook and bake. I just had a baby. She's 2 months old. So I love spending time with her and trying to make my dog feel less abandoned. That's lately the balance. So yeah.
And we have last but not least, Jessica. She's an internal medicine resident in Women's Health Track in Northwestern. And yeah, welcome, Jess. And if you want to tell us what you like to do outside of medicine too.
Sure. Hi, everyone. So excited to be here. Thanks to everyone for inviting me and having me on the virtual morning report. I also am new to Chicago and particularly love the lakeshore here. So looking forward to the warm weather coming when I can spend a lot of time on our beautiful lakeshore, either running or walking with my dog. Excited for that.
Thank you. I have one more question for Amy and Gabby, and why pulmonary and critical care? I really like pulmonary and critical care, so what do you girls advise me? Should I continue in this way or should I change?
You should absolutely do pulmonary and critical care. What drew me to it was, intern year, it's very overwhelming, but it's also just like the best physiology, right? The breadth of disease that you'll see. And also you learn it just very, very well. So breadth and depth, basically. I feel like I don't actually have to give up any organ systems, even though I am a subspecialist, because we see everything. And I really enjoy working with my hands. And so the procedural aspect of it is really cool too. Plus just the acuity of the disease presentation and the resuscitation. There's a sort of an adrenaline rush to that, but also you have the ability to make a huge difference in your patients' lives too.
Yeah, I would definitely echo everything that Amy said. I think pulmonary physiology is what draws a lot of people in. I mean, it's really tough. It took me, even now I still feel like I'm still learning all the time and learn from lots of different lectures we get on pulmonary physiology, but I think it's super interesting. And I also really like, as somebody who's interested in ILD, I really like the imaging aspect of pulmonary. I like just be able to like see what's going on like a CT scan. So I really like that aspect of pulmonary and just being able to like visualize what's going on in the lungs. And I just in general feel like it's definitely kind of like a team sport. And definitely in the ICU, you're always working with the team, working with different consultants. But especially in like interstitial lung disease, I feel like a lot of it's a team aspect because you can get a lot of weird, crazy cases that don't fit nicely into any specific bucket. So I think it's super common. We have our ILD conference where we discuss interesting or difficult cases, or even ones that we just want to sort of a consensus on. So I really like that aspect, and that you're always working with radiologists, pathologists, other pulmonologists to, try to figure out what's going on with your patient.
Thank you for answering the question. So I think we can keep going with the whiteboard. Sarah, please. So yeah, Jess, whatever you want to start with the case.
Sure. So on day 5 of admission for this patient, the MICU is consulted on a 63-year-old male who's admitted to the oncology service with an escalating oxygen requirement and shortness of breath. Overnight, he developed a 4-liter oxygen requirement. He was placed on nasal cannula in the middle of the night. But then in the morning, he was noted to have an SpO2 in the 70s on 4 liters nasal cannula and was placed on 6 liters non-rebreather. So a rapid was called, and then the MICU was consulted, and then put yourself in the shoes of a day 1 MICU senior running over to the oncology service to see this patient. When you talk to him, he endorses mild shortness of breath. He has no chest pain, no palpitations. He doesn't feel confused. And the primary team is at bedside and says he's maybe slower to respond than he was yesterday, but his mental status is still improved from admission. Do you want me to stop there, or do you want me to do a little bit of exam and vitals?
That's probably a good place to stop. Or yeah, I think that's a good place to pause. I mean, I think you already gave us a lot of really helpful information to sort of dig into. So, and yeah, this is like probably, the bread and butter for the MICU seniors who are, on call, taking on new consults, taking on new admissions. So I feel like this is probably what we see most often, which is sort of acute worsening of whether or not it's acute or sort of acute on chronic hypoxemia is definitely something we see super commonly. So I think you already gave us, a ton of helpful information. Like this is day 5 of his admission. So, I think trying to figure out what sort of changed in the last day, it sounded like there was something acute going on. So I think that helps sort of narrow down when we think of the different causes of hypoxemia. That can be really helpful knowing the acuity of when it's coming on. So I think we'll probably hear at some point sort of what's been going on during the admission and what did he initially come in with. But I think trying to figure out what happened sort of in the last day, which caused this acute worsening of his hypoxemia. So, I think we could pause now and sort of go through the different causes of hypoxemia and how we, use the acuity of events to try to figure out what's going on. I think always running through, the sort of different causes of hypoxemia can be like a helpful exercise. So thinking about whether or not, again, I think, the usual, when we think about the causes of hypoxemia, we usually first go down the route of, is this, thinking about the alveolar arterial gradient, the AA gradient. So thinking about, do they have a normal AA gradient or do they have an elevated AA gradient? And in order to calculate that, you need to know sort of what should their alveolar oxygenation be. And so I think that is actually helpful in this person's case, because when we think about the alveolar gas equation, sort of the main things that go into it are sort of the fraction of inspired oxygen. So we know that, for this person, they're already on supplemental oxygen. So they're not, in a low oxygen state. They're in Chicago, so we're more or less at sea level. But I think the one element that can change a lot that we don't always think about, but when you look at the alveolar gas equation, you see that it matters a lot, which is the CO2. And so that really tells us, is a person hypoventilating? And so I think that is definitely something that you can see happen acutely, especially, you gave us a bit of information that sounds like they're maybe a little bit more out of it. They're more somnolent, I think you said, or just slower to respond. So is that a sign that maybe his CO2 is rising? Is he hypoventilating? I think there's lots of different causes of hypoventilation, but is it like iatrogenic? Was he, has he been getting different sedating medications that could cause hypoventilation? So I think that's definitely something to sort of keep in the back of our mind. And then thinking about the other causes of hypoxemia, like VQ mismatch, shunt, diffusing barrier, diffusion barrier. Again, when we think about the acuity, like a diffusion barrier, like an ILD doesn't just happen overnight. So that seems less likely. So that's, again, how thinking about the acuity of somebody's presentation can be super helpful. So then sort of getting down into like VQ mismatch shunt, which I think we'll get a lot more information from with his exams, trying to figure out what's going on, getting imaging. But I think that's sort of a way to start thinking about sort of acute hypoxemic respiratory failure. I don't know, Amy, if you have anything else to add.
Oh my gosh, no, that was great. I think you did a really great job of breaking down sort of our differential when we think about a hypoxemic patient. The only one thing I want to add is, when you're being called to a rapid, part of the decision making there in the moment is deciding whether or not this patient needs ICU level of care, right? Because they're on an oncology ward, they've had some supplemental oxygen, but obviously now things have changed. And so I always like to stick with the ABCs initially when triaging these types of patients. Are they breathing on their own? Do I have to worry about their airway? What do their lungs sound like? And then how are their vitals and peripheral pulses and whatnot. And so I think that would be an interesting thing to hear about during their exam and their vitals. So yeah.
Oh, thank you. Yeah, I think we have a lot of students, and I have a question, like how you can make the difference between hypoxia and hypoxemia, and if any of you can answer that.
Yeah, I mean, I think oftentimes so hypoxemia, emia is in the name, so that means it's your blood level of oxygen. And so that's usually what we mean when we're referring to, when we're talking about somebody whose oxygen levels are low. So either you're checking that on a pulse oximeter or you're checking that with a true ABG. That's usually what we're talking about, is hypoxemia, meaning they have a low amount of oxygen in their blood. Hypoxia, though, is really that your tissues are not getting enough oxygen. So that, in some ways could be potentially the more clinically relevant measure, but it's usually not what we're talking about when we see somebody with, they're desatting, they have a, low level of oxygen on an ABG. We're usually referring to hypoxemia, but I think it is important to make that distinction between hypoxemia and hypoxia, because really we want to make sure, the hypoxia is more or less what we're actually worried about. We want to make sure that we're getting enough oxygenation to our organ systems, to our brain, to the heart. So, but usually, that's a little bit more difficult to measure. You can't just measure that with a pulse ox. You have to look for signs that you're not getting enough sort of tissue oxygenation. Hopefully that answers your question. I don't know, Amy, if you have anything.
Yeah, no, I think Rafa wrote it pretty well in the comments. Hypoxemia is a cause of hypoxia. So it's sort of like a broader umbrella category. And like Gabby was saying, you usually need more information if you're looking at, other causes of hypoxia, like anemia or other toxins that can cause abnormal binding of your oxygen on the hemoglobin units. And so It's a little tricky, and I think we use these terms interchangeably when we shouldn't, right? Because there is a distinction.
Thank you. Yeah, Jess, if you want to continue with the case, please.
Sure. So to go into the vitals and exam, since we are kind of evaluating in the moment for this case, he's currently afebrile, has been afebrile his whole admission. His pulse is in the 90s. He's saturating 72% on the 6 liters non-rebreather. When you examine him, he's sitting in bed. He looks fairly comfortable. HEENT exam is pretty unremarkable, but lips and oral mucosa are notably moist. They are a little pale. His cardiac exam has a regular rate and rhythm, no murmurs, rubs, or gallops. No JVD is seen. For his pulmonary exam, he has relatively normal work of breathing. He's maybe breathing a little quickly, but nothing crazy, and he's clear to auscultation bilaterally. Abdomen is benign. His extremities are warm and well perfused. He has no edema. And then you see the condom cath bag is draining clear yellow urine. And as far as the neuro exam, because we were worried about him being a little less responsive, he's ANO ×3, and he is able to follow commands, answer questions appropriately, et cetera.
And Jess, what was his blood pressure?
153/65. Sorry, I don't know if I mentioned it.
Interesting. So obviously he's a man with slightly increased work of breathing subjectively, maybe. Sounds like his respiratory rate is a little bit high. But notably from his pulmonary exam, his work of breathing and his auscultation seems relatively benign, right? We're not really picking up any parenchymal abnormalities like crackles or diminished breath sounds. So I'd be interested to see what his imaging looks like. And he doesn't seem to be responding when we crank up the oxygen, right? He's still 70% by the time you get there on 6 liters non-rebreather. And so oftentimes when people are not improving with oxygenation, it makes me think of shunting, right? Because that usually doesn't improve with oxygen supplementation. So overall, he sounds pretty stable from a hemodynamic standpoint, but certainly from an oxygen needs requirement, it sounds like things are escalating and the numbers are not improving.
Yeah, I think really great job, Amy, sort of taking us through that and thinking about all the vitals all the exam findings and how that could sort of point us towards, what potentially could be going on. I think, Amy, you brought up a really good point earlier about like when you're the MICU senior going to evaluate these people, really you want to be thinking about sort of like ABCs, how sick is this person? And I think, the fact that he is breathing relatively comfortably, normal work of breathing, I think you probably do feel like a little bit of a sigh of relief because you really want to assess like, do I need to establish an airway? Is he in respiratory distress? Do I need to be thinking about, interventions right now? Because that's often, in critical care, something that you're doing, which is you're doing diagnostics and therapeutics at the same time sometimes, potentially having to sort of do things without entirely knowing what's going on, what is the cause of their decompensation. So I think, Amy, that was a really good point that you brought up earlier that, assessing like, do we need to establish an airway right now? How is their circulation? So I think the fact that he's, obviously he's only satting 72%, which is can be really scary when you see that. But I think it is helpful to say that, to know that he's not in any sort of like respiratory distress. He's awake, he's talking to you, which gives you a little bit of time to like figure out what's going on rather than like just immediately call an airway and try to just, think straight to therapeutics before, trying to figure out exactly what the cause of the decompensation is. So I think that is like a helpful bit of information.
Yeah.
But I think Amy.
Sorry, one additional point I just wanted to bring up was the pulse ox seems to be the biggest abnormality, right? Like he's desatting far lower than and that's not really reflective in his exam, right? I would have expected him to be maybe approaching cyanosis, like rapid breathing. And so one thing that I like to think about when there's a discrepancy between the numbers and the physical exam that I'm seeing is, can I trust my SpO2, right? Because pulse oximetry at the end of the day is absorption of light. And so if there are things that interfere with that, like methemoglobinemia is one of them, or even, nail polish, or if a patient has just some sort of perfusion deficit that might affect the way that it's picking up on the pulse ox, and that might actually artificially lower the reading that we're seeing.
Yeah, I saw Rafa's question here about escalating to CPAP or BiPAP in somebody who's hypoxemic. So, that's a really good question. We want to think about, okay, so this person's already on a non-rebreather. What can we do for them while they're still on the floor? I think, Amy brings up a really good point, trying to figure out, like, are we getting like a good pulse ox reading? Do we have a good weight? Do we have some sort of device where we can actually look at a waveform to feel like this is a true, this is a good representation of what their actual oxygen level is? So I think that's one thing. But then potentially thinking about, like, where can we escalate beyond a normal nasal cannula. So I think, that's definitely something you're thinking about when you're trying to, escalate their care and you're trying to potentially bring them over to the ICU. So I think, a non-rebreather is really helpful because you can breathe nearly 100%, basically almost 100% FiO2, depending on what their work of breathing is. But again, you can only deliver so much flow with a non-rebreather. So if you're giving 6 liters of oxygen, even though you have this reservoir bag that allows you to get close to 100% FiO2, if your minute ventilation is 30 liters per minute and you're only delivering 6, again, you could potentially be getting in room air that actually causes your inhaled amount of FiO2 to be lower. So, I think a non-rebreather can be really helpful, especially in transporting somebody to the ICU. We often think about high flow nasal cannula, which is usually our go-to in people who have pure hypoxemic and not hypercarbic respiratory failure. That's based on the Florali trial, which essentially showed that people who were not hypercarbic, didn't have any signs of hypoventilation, had lower mortality if you used high flow nasal cannula compared to something like a non-invasive ventilation. So, I think part of this question of, like, whether or not this person needs BiPAP or CPAP, I think again gets down to the question a little bit of, like, what do we think is going on? What do we think is the cause of this person's? Do we think they're actually hypoventilating and would potentially benefit from something like BiPAP? When we think about CPAP, CPAP can be helpful and has been shown to be helpful in people who have cardiogenic pulmonary edema. So, looking at you provided a really helpful exam, which is that, he doesn't have any JVD, he doesn't have any lower extremity edema. So maybe puts cardiogenic pulmonary edema a little bit down on our differential, but I definitely think something to think about, especially in somebody who's been in the hospital for 5 days, iatrogenic causes of hypoxemia, like giving somebody a lot of fluids, is something to consider. But I think for transport, again, you can't really transport somebody on high flow nasal cannula. So I think, potentially if they're not in any sort of respiratory distress, transporting them on the non-rebreather, or if you have access to some sort of PAP therapy, I think that would be something to try as well. But yeah, I think somebody brought up, we need a lot more history about sort of, why are they here? what has been going on for the last 5 days? What's their history? I think it's going to be really helpful when we are trying to piece out sort of what's going on. But again, I think you bring up a good point, Jess, that we often don't, or I should say you don't have this information when you're going in as the MICU senior. You just kind of show up to the rapid response, like there might not be the primary team there who knows what's going on. You probably are usually showing up with about this much information, which is that, I don't know, they've been here for 5 days and they're desatting and that's all I know. So I think a lot of times we are just acting on the little bit of information that we have. And then, once we get them over potentially to the ICU settled in, we can start thinking about sort of what's been going on in the background and try to figure out what could be causing their decompensation.
Yeah, I tried to keep it true to the real-time experience.
Totally. I know you guys have a really tough job. As the fellow and attending, we have, time to think about it, sit at our computers. So yeah.
Thank you. Thank you, Jess. If you can give for us the past medical history.
Yeah. So his only real past medical history is IgG kappa multiple myeloma. It was diagnosed about a year ago. He had a pathologic hip fracture and an associated lytic lesion, which then resulted in a bone marrow biopsy with 5 to 10% plasma cells and a right hip arthroplasty as the final diagnosis for him, showing a plasma cell neoplasm within the lytic lesion. Since then, he's been on daratumumab, zoledronic acid, and dexamethasone. It's a little unclear talking to him whether he's been taking these reliably, but that's what he's been treated with. He presented, like I said, it's hospital day 5 today. So he presented 5 days ago with progressive abdominal pain, vomiting, and altered mental status, and then was found to have a calcium of 19, a low vitamin D, and low parathyroid hormone. His CT chest, abdomen, pelvis showed innumerable lytic lesions of the ribs, spine, and extremities, all consistent with hypercalcemia of malignancy, which he's been treated for since then, with normal saline, 200 cc's an hour, and calcitonin. He also had an AKI when he came in. His creatinine was 2.9 from a baseline of 1, thought partly from the multiple myeloma and the hypercalcemia, but also was found to have hyperuricemia to 13.3 a few days ago. So for that, he's been given allopurinol 300 milligrams every day, and then he did get 1 dose of rasburicase. His other medicines currently are sub-Q heparin, magnesium oxide, some Miralax, and then Senna as well. But really no other past medical history prior to the diagnosis of multiple myeloma.
Yeah, I think, and how all this can contribute to the differential of the hypoxemia in this patient.
Yeah, so when I hear this history, my goodness, this man has had a lot going on recently. Sounds like abdominal pain, hypercalcemia, lytic lesions, all very consistent with his multiple myeloma diagnosis, brought him in initially. And the floor was absolutely right to hydrate this man's kidneys, right? Since he already presented with an AKI, and that's part of the treatment for hypercalcemia. It does sound like he's been getting a lot of fluids, 200 cc's an hour over the last 5 days, and presenting with hypoxemia now. That's one thing that we commonly see in hem-onc patients, right? They're getting fluids for chemo, fluids for tumor lysis syndrome or hypercalcemia. And so the tendency is that more often than not, they get fluid overloaded, which can present with hypoxemia in the form of acute mismatch, right? And so that's pretty much number 1 on my list of things to think about for this patient. Jess, what was the dexamethasone for? Can you remind me again?
He was on it as a home medicine for his multiple myeloma treatment.
Oh, okay. Sounds good. So, the other thing that I think about in these immunosuppressed patients. He's getting chemo, he has cancer, he's taking steroids, is infection. And so it doesn't sound like there's been any preceding symptoms or history that would be consistent with that. He's afebrile, but certainly I would want to interrogate that and make sure that that's not something that I'm missing. So a bacterial pneumonia, or if he's been in the hospital for now 5 days, or has had a recent admission, thinking about things like, pneumonia with risk factors, and then viral and fungal as well.
Yeah, and I know the chat's blowing up with this raspberry case call that somebody made it early on in the case. I think it was just like got the one-liner, and somebody was like raspberry case. So I'm super impressed. But I think that's definitely, now I feel very anchored to raspberry case. I'm like, oh my gosh. But I think, yeah. So somebody in the chat brought up a really good point that thinking about rasburicase-induced methemoglobinemia. So I think, common things being common, I think Amy brought up a lot of really good points of like, 99 times out of 100, this is going to be volume overload. And that's what we see on, a daily basis, is people coming in with volume overload, especially in this patient's case where, they're getting a ton of fluid. So, I don't want to anchor too much on sort of more rare causes, because again, we see things like volume overload and iatrogenic causes of hypoxemia so often. So I think it's definitely something that it's going to be helpful to evaluate for, when we get our chest imaging. We can do things like ultrasound, POCUS to try to get a better sense of, are there signs of volume overload? But yeah, I definitely think that, especially in this person who their oxygen level is so low, 72%, but they look pretty comfortable. I think thinking about causes like methemoglobinemia is definitely something to consider, especially when they're just been given a drug that's known to cause it. So I think that was a really good pickup from somebody in the chat there. So yeah, and to get a better sense of, and to evaluate that, we're going to need a lot more labs and imaging, but yeah, getting an ABG, which, we don't always necessarily need in people who are hypoxemic, but I think you can get a lot of helpful information, especially in this case. And I think, like we talked about there, pulse ox isn't always sort of infallible. Sometimes pulse ox, again, like in the case of methemoglobinemia, you can be fooled. But then also, there's lots of data showing that people with darker skin tone, it can also potentially, you're at higher risk of having like occult hypoxemia that's not picked up on the pulse ox. So I think there are lots of reasons to at least get an ABG when somebody's coming in with acute hypoxemic respiratory failure.
And I have a question. When are the cases that you order a ABG, and when is the cases that you order a VBG?
Yeah, that's a really good question. So an ABG is an arterial blood gas versus venous, right? And so you're sampling the arterial side. In an ABG, you're going to get a true PaO2 or partial pressure of oxygen. Arterial pressure of oxygen, and then in the venous blood gas you won't, and you'll get a true CO2 measurement as you would in an ABG. And so in this case, we're worried about his oxygenation and his SpO2 maybe being inaccurate. I would definitely get an ABG for this man, and in that case we'll also get evidence of hypercarbia if there's that present, and be able to do our AA gradient from there. Yeah,
I would say, in this case, so say it wasn't, say we didn't have this big concern for methemoglobinemia. I think getting a VBG is always a good sort of first pass, especially if you have a good waveform on the pulse ox, because yeah, again, there is pretty good correlation between the CO2 level on a VBG and an ABG. And it's pretty good at sort of ruling out true hypercarbia. So if you're PCO2 is less than 40 on a VBG, the likelihood of you having actual hypercarbia, true hypercarbia on an ABG is really low. So it has like a good negative predictive value. But again, if you're, I would say the cases that we get a true ABG, or that we would want an ABG over VBG, is if we really want to follow that PaO2 closely. So again, I think it can be helpful just to at least get one to, again, sort of rule out these more rare causes of hypoxemia, especially if it's not really fitting with any other clinical picture and you're sort of still scratching your head as to what could be going on. The ABG could potentially be really helpful and give you some additional information like methemoglobin levels, things like that, carbon monoxide. And then, I think oftentimes we'll get it when we're trying to really closely follow somebody's PaO2 and somebody who has like ARDS. I would say that's the more common time when we're actually following it over time, as opposed to just getting one and then sort of correlating it with the pulse ox, because a lot of our decisions in ARDS can be come down to like the P to F ratio, which you need the actual PaO2 from an ABG on. So in somebody who has really severe ARDS and you're making sort of changes to a ventilator and you want to say, how did going up on the PEEP in this person with ARDS affect their P to F ratio? Am I improving their oxygenation with these changes that I'm making on the ventilator? That would be a reason to follow an ABG. Or, say, do I need to prone this patient? I've maximized them as well as I can with the ventilator, but they're still hypoxemic. So then, looking at their P to F ratio to say, if it's below 150, there's good evidence from our trials of proning that things like proning could be helpful in ARDS. So I would say that's usually the time when we'll track ABGs throughout somebody's stay in the ICU is really usually when somebody's coming in with like bad ARDS and we want to know how is our intervention changing their oxygenation.
Thank you so much. Jess, if you want to give us some labs.
Sure. So you are unable to get a blind ABG, unfortunately, over in the oncology unit, but you do get a VBG, which is 7.43 for the pH with a CO2 of 39 and an oxygen of 69. His CBC has a white blood cell count of 7, a hemoglobin of 7.1. It was 7.4 yesterday and 8.9 at admission. His platelets are 234. As far as chemistry, sodium is 135, potassium is 3.7, chloride 107, CO2 24, and then a BUN of 30, improved from 50 at admission, and a creatinine of 1.99, which is improved from 2.9 at admission. And again, his baseline is 1.0. His glucose is within normal limits. His calcium is now down to 11.2. And his magnesium and phosphorus are fine. As far as LFTs, his AST is 37, ALT is 12, ALK-Phos is 63. His total bilirubin is 0.9, and his total protein is 10.3 with an albumin of 3.0. They also send a lactate, and it is 0.7.
Are you going to give us imaging, or is that the next aliquot?
I can give imaging now. That's fine. Deborah, do you have the slide of the chest X-ray, or do you want me to just go through the read?
I think I have. Wait.
I guess while we pull up the chest X-ray, we could probably walk through some of, what we got. I think we talked about what can we get from a VBG, and I think we have gotten some useful information from this VBG, which is that, he doesn't appear to be hypoventilating, which again was sort of one of those potential causes of hypoxemia that we could potentially be worried about. So again, his pH is normal, his CO2 is normal, his CO2 is again below 40. So the likelihood of him hypoventilating and actually being truly hypercarbic on an ABG is very, very unlikely. So I think that's helpful. The fact that his partial pressure of oxygen is 69 on a VBG potentially also points us to, there's a lot of oxygen dissolved into his blood because, on a VBG, again, we don't usually look at the O2, the PO2 on a VBG because it's usually super low and doesn't really correlate with the PO2 on an ABG. But the fact that this is like relatively what would be in the normal range for somebody on an ABG potentially tells us that there's still, there's a lot of dissolved oxygen, sort of not the oxygen that's not bound to hemoglobin, at least even that we're detecting on a VBG. So I am very curious to see what that would be on an ABG, comparing his SAT on the ABG and the dissolved PaO2 on the ABG.
Mm-hmm. Yeah, that was excellent. I think the other pertinent negatives, his white blood cell count is relatively normal. His creatinine is improved. His LFTs sound pretty stable and his lactate is negative. So that's all reassuring. The one thing that kind of tickled my ears was that his hemoglobin has been downtrending since admission, right? He is almost 2 units down, 2 grams, which may indicate either dilution. It doesn't sound like clinically he's bleeding from anywhere. He's not reporting hemoptysis. We're not hearing of any signs of GI bleeding. His BUN is improved, right? And so this kind of even makes me think about hemodilution and possible fluid overload as the cause of, potentially his hypoxemia.
I can show the chest X-ray. Just 1 second. Everybody can see?
Yeah. Is there a way to potentially make it a little bit bigger or no?
Wait, let me try.
Like full screen it?
Is better?
Yeah, perfect. Thank you. So when I approach chest x-rays, I like to read it systematically just so that I go through every film the same way every single time and I don't miss anything. So the first thing I look at is this airway. It looks like it's patent and midline. I will not pretend to know bones on x-ray, so I'm going to skip that. But the cardiac silhouette looks probably normal. This is a portable AP film, so sometimes it can seem a little bit bigger just because of the way that the image projects onto the screen, but this looks like you can see both sides of the cardiac silhouette and it's not taking up too much of the thorax in terms of the territory, so that looks good. And then I look at the diaphragms, examining my costophrenic angles, and so it looks pretty crisp on both sides and well delineated. I don't see any pleural effusions or anything there. And then everything else would be your lines and tubes and your lung parenchyma, right? So I see that this man has a port that's terminating in probably the cable atrial junction. He otherwise has just some external leads. And then for lung parenchyma, you see these, kind of interstitial opacities that are pretty diffuse, I would say. And I don't see any large size consolidations here. And there's definitely no pneumothorax, and I can see lung signs everywhere. And so I think the main finding from this that I would take is just some diffuse interstitial opacities.
Yeah, totally agree. That was a really great job, Amy. Yeah, I definitely agree. He has this hilar fullness that I imagine is probably related to his, multiple myeloma, but I doubt is the cause of his, acute decompensation. So I think, yeah, the most notable thing, like Amy said, is the fact that really we're not seeing a ton abnormal in his lung fields. We're not seeing any sort of anything that looks like new pneumonia. I think this fits with his exam. Again, we were talking a lot about, could he have pulmonary edema from all these fluids that he's been getting? But this sort of is pointing us away from that. We're not seeing what looks like a lot of pulmonary edema. So in general, I would say, yeah, his parenchyma looks pretty normal, which I think is notable in this case in somebody who's satting 72% on 6 liters. So yeah.
Thank you. I think we can continue with the imaging, I guess.
Sure. So that's the only sort of acute imaging we get. You get him to the MICU, he's put on high flow nasal cannula. He's on 50 liters, 70% and is still satting about 88%. They agree with you guys that, there might be some pulmonary edema. So they go ahead and give him a little bit of IV diuretics just to cover that base. And then do you want me to move on to the final part just to make sure? Yes.
I mean, I guess, I don't know if we want to pause here and sort of talk about what we would do once we're here, and I don't know, Amy, if any additional things you would do now that he's sort of getting in, settled to the ICU, you're coming in as like the fellow. Okay, what's going on? I don't know.
Yeah, I think so he's still pretty hypoxemic despite escalating to 70% and significantly more flow, right? And so I'd like to kind of take a step back and re-examine and think about, again, his lung exam. Is he still comfortable? Have things changed? I would love to get an ABG and test for his PaO2, check for carbon monoxide, check for methemoglobinemia, like all the things that we've talked about. And then I think for this patient, just being really broad with his differential, still getting, markers of infection like procalcitonin. If he's making any sputum, sending that for infectious testing, like a culture. And then, yeah, kind of seeing if he improves with diuretics, that would be helpful to know, and go from there. Potentially a CT scan if things are not revealing, because pulmonologists love their CT scans.
Yeah, great job, Amy. I totally agree with everything you said. Artem in the chat said POCUS exam would be helpful too. I totally agree that, especially in somebody with this chest x-ray that's like a little like, not super revealing. It's definitely not giving us our answer. POCUS can be helpful. The things that we're looking for in terms of trying to figure out causes of hypoxemia would be, we want to look at, do they have evidence of B lines, suggesting that there's some sort of alveolar filling process, whether, so maybe there is some evidence of pulmonary edema that is not so, maybe he did have some interstitial fullness in the chest x-ray, but it's not like slam dunk. He's obviously overloaded. So I think seeing a lot of B lines on a POCUS, on your POCUS exam could be really helpful to show us that there is something sort of fluid filling, something filling the interstitium, especially, if he had normal lungs beforehand, that would potentially move us towards there being pulmonary edema. You could see, is there some sort of like pneumonia or atelectasis that we didn't get a good look at from the chest x-ray. So I think POCUS, could be super helpful. A cardiac exam, I think, is always helpful coming into the ICU. So I think one thing we haven't talked about, is something like a PE. I see he's been on sub-Q heparin, but I still think something to keep sort of in the back of our mind as a cause for why he's so hypoxemic with a normal-ish chest x-ray. So looking at his heart with, doing POCUS can be really helpful. So is there evidence that the right side of his heart looks overloaded? Are we seeing that his RV is really dilated? Things like that, does he have a really plump IVC on his POCUS exam that could potentially, maybe push us more towards getting like a CTPE study, in somebody, especially in somebody who has this AKI, has this elevated creatinine. Sometimes that's like a little bit, you have to think about like risks and benefits of giving somebody IV contrast. So that might push us one way or another. Things that we see on a POCUS exam could potentially push us towards or away from giving him contrast for like a CTPE study. But again, I think, the ABG is going to be super helpful. POCUS is going to be super helpful. And if that's not giving us our answer, I think Amy, brought up a really good point that CT, we're pulmonologists. We always like CTs and ICU doctors. It's hard for us to get away from, CT scanning everybody who comes in. So I think I love a CT scan. So I would definitely be something I'm thinking about.
I really like that you all like the CT scan. So yeah, Jess, if you can give us more information.
Yeah. So I am trying to recall, I don't know that it's in the notes, but I think we did do bedside ultrasound, and both right and left heart function seemed within normal limits. There were no B lines on his lung exam. And then, so to kind of get to the final labs that we order, so we do get an ABG ultrasound guided in the ICU. It's 7.47 for the pH, the CO2 is 34, and his oxygen is 214. So then based on all of this, and you guys have been bringing this up all along, we do send an arterial methemoglobin saturation, which is 23%. A G6PD level had been sent a couple of days before the raspberry case, but had not come back yet. And when it did eventually come back, it was intermediate level. And then based on the anemia that Amy pointed out, we did also send a blood smear at the time, which showed normocytic anemia with red blood cells having polychromasia, markedly increased anesopoikilocytosis, including frequent blister cells, occasional bite cells, and circulating nucleated red blood cells, consistent with Heinz body hemolytic anemia. And so our final diagnosis for the case is Heinz body hemolytic anemia and methemoglobinemia secondary to raspberry in the setting of G6PD deficiency.
Amazing. Shout out to whoever that was in the chat that called it within the first 2 minutes of the case. I'm super impressed. But yeah,
Absolutely.
I know, but yeah, I think the ABG is super, obviously gave us the answer here, even initially, because with a with a PaO2 of 214, all of our ABGs, at least here, come with saturation, a hemoglobin saturation for oxygen. So I imagine as long as that's also correlating with what we're seeing on the pulse ox and it's in the 70s, that tells you that there's something else binding to hemoglobin that's preventing oxygen from binding, because it's not that the fact that oxygen's not getting into the bloodstream, because we see that the PaO2 is 214, so presumably the alveolar concentration of oxygen is super high. It's able to diffuse into the bloodstream easy enough, but it's not able to bind to the hemoglobin, which is what's causing the hemoglobin saturation to be low. So is there something else that's binding to it? Which ultimately ended up being methemoglobin for this patient. So yeah, super interesting case. That's really great. I mean, yeah, not something, I mean, we see it every once in a while, but definitely sometimes, we usually don't pick it up right away. And it's usually after we're trying to like diurese somebody, we're not really figuring out like what's going on. Sometimes it can take a little bit of time to pick that up and figure out what's happening.
So a methemoglobinemia percentage of 23% is probably the highest I've seen in a while. This isn't something that's super common. It's one of the more rare causes, right? And I think given that category, we would classify this as severe. Is that right, Jess? And so this would be something that would necessitate treatment, like with methylene blue. And so that's what I would be talking to my pharmacist next about in terms of dosing that for him and, hoping hopefully getting that on board so that we can treat that since he's not improving with increasing oxygen supplementation.
Yes.
Methylene blue, yeah. Oh, sorry, go Jess.
Yeah,
So,
yeah.
I imagine you maybe have some teaching points or something about.
Really just one major one, which was, and I'm not sure about the exact cutoff, but the first thing we did was go to our pharmacist, Amy, and say, you know, how do we dose this? Does he need treatment? What should we treat him with? I think I remember them saying that actually 30% was you actually mandatorily need to treat it. But because he was symptomatic and getting worse, we did go ahead and treat him. But in patients with G6PD deficiency, you actually want to use ascorbic acid or vitamin C instead of the methylene blue. So very glad we discussed with our pharmacist because they were key for that. So he got 5,000 milligrams every 6 hours until his percentage had dropped below 5%, kind of arbitrarily. And one thing I was hoping you guys could tell us about actually is because this is something we kind of struggled with managing in the ICU and was a huge effort to coordinate with nursing as well to, you know, manage expectations about what his O2 stat was going to be, that kind of thing, is how would you actually titrate his oxygen therapy going forward, knowing this diagnosis? Because, you know, he's still only 88% on the high flow nasal cannula. And that's what's keeping him in the ICU as well.
Yeah, I would say some of the things that are, you know, again, we were talking about the differences between hypoxemia and hypoxia. So again, the hypoxemia is what's easy for us to measure, but the thing we're really worried about is tissue hypoxia. So I think following signs that he is not getting enough oxygen delivery to his various organ systems. So like, what is his mental status like? Is he any sort of like respiratory distress? Is he, you know, does he have his lactates normal? Does his lactate remain normal? I think signs that he's getting enough oxygen delivery can be really helpful. And I think sort of reminding people that, you know, no matter how much you turn up the oxygen, even at 100%, you're not going to be able to get his oxygen saturation up above a certain level. So, you know, this is not somebody you're going to be like intubating to put them on PEEP and, you know, do other things that we would normally do to try to improve oxygenation. But I think when we think about oxygen delivery, you know, if you think about that equation for what determines oxygen delivery, you know, the bulk of that is going to come from your oxygen that's bound to hemoglobin. And so in our case, you know, that's going to be low, but you do get a small amount that's just from the dissolved oxygen in the blood. So that might be one reason to potentially aim on the higher side of just giving him more oxygen, because at least you're going to dissolve some amount of oxygen in the blood, even if it's not bound to hemoglobin, and potentially augment, you know, your oxygen delivery somewhat, even in a small amount, just by dissolving more oxygen in the blood. So again, you know, it probably doesn't hurt just to put them on 100% oxygen and makes everybody feel better that we're doing something, but so, you know, I probably wouldn't do anything beyond that.
I think you can also reassure your nurses, right? You have evidence that on 50 liters, 70%, his PaO2 is in the 200s, right? And so, you know, this might be, it's just really looking at the numbers thing, but, you know, I think it would be impractical to titrate based on an ABG, right? Because that would also necessitate probably keeping him in the unit in a higher level of care. But that can at least give some reassurance, and then following those methemoglobinemia levels as you give treatment, and perhaps periodically checking like a random ABG once in a while, just to see if you can potentially come down on that, I think is another management approach too.
Thank you so much, Jess, for this incredible case. Thank you, Gabby and Amy, for all the pros and all the discussion. It was a really great section. And I want to pass the mic for Jess for some teaching points that we have from the case.
Yeah, thanks, Deb. And thanks, Jessica, Amy, and Gabby for such a great case and discussion. I tried my best to capture everything, but you guys were giving off too many teaching pearls for me to capture everything. So, so I'm going to start off by saying hypoxemia versus hypoxia. What's the difference in terms of definition? So hypoxemia is low oxygen levels in your blood, and hypoxia is low oxygen levels in your tissues. Hypoxemia is the cause of hypoxia. Helpful to know the acuity of hypoxemia. I think Gabby started that off, given that this happened during the hospital admission. So you want to think about hyperacute versus acute, and emphasizing that ILD doesn't happen overnight. So you kind of want to focusing on other possible etiologies. Thinking about the AA gradient. If it's a high AA gradient, you want to look at an alveolar cause, whereas a normal AA gradient, think extrapulmonary causes. So could this be a VQ mismatch? Again, given acuity, ILD seems less likely, vascular phenomenon could be more likely. CO2 levels changes from patient to patient, and you want to ask yourself, is the patient hypoventilating or hyperventilating? And then when patient is not improving on oxygen, you want to think about, is there a shunt somewhere that is contributing to this lack of improvement? When you are seeing a patient that is not improving on oxygen requirements, you want to assess the ABCs and basically see if this patient's airway, breathing, and circulation is adequate, or if this needs further intervention. When there's a discrepancy between the clinical picture and the pulse ox, you want to think about methemoglobinemia, perfusion defect. Is there any nail polish on the nails? Or is there just individual and darker skinned? Because studies have shown darker skinned individuals may have a occult hypoxemia. Then we briefly talked about CPAP versus BiPAP, and CPAP specifically compared to BiPAP could be helpful in cardiogenic pulmonary edema, whereas BiPAP may be better in hypercapnic situations. BiCAP also decreases the inspiratory work of breathing and can improve diaphragmatic function better than CPAP alone. Patients with cancers typically get more fluids than the average patient due to AKIs, infusions with their chemotherapies, putting them at risk for pulmonary edema. Given immunosuppression, at risk for this patient was at risk for infection, not only for your typical infections, but also for fungal and atypical, such as PJP. And then very early on in the chat, and then it was brought on again, was the respirocase can also lead to drug-induced methemoglobinemia. However, this is rare. You want to focus on common things first that can lead to the hypoxic respiratory failure. Then we talked about ABG versus VBGs, and when is one better than the other. ABG will give you a true PO2, VBGs will give you a true PCO2. For acid-base disorders, this should be equivalent. If the PaCO2 is less than 40 on VBG, hypercarbic states are less likely, has a great negative predictive value. Changes in ventilator settings, however, ABGs are preferred, even though we typically do not look at oxygen on VBG. This patient's VBG did have a pretty normal range of oxygen, which brings you the possibility of possible dissolved oxygen. And then Gabby brought up at the end that even dissolved oxygen at times can provide enough oxygenation to the tissues. H&H or hemoglobin hematocrit downtrending since admission, no evidence of GI losses. Could this be hemodilution versus hemolysis? Given persistent hypoxemia, ABG would be helpful. Obtaining sputum samples, especially when this patient was not improving. Would also prefer to get a CT scan. Lastly, the use of respirocase is contraindicated individuals that have G6PD deficiency and should be screened for individuals who are at high risk. And then treatment is methylene blue. However, in patients with G6PD deficiency, you'd want to use ascorbic acid, also known as vitamin C. Oof.
Thank you so much, Jess, for these teaching points. And thank you so much, Gabby and Emmy and Jess, for being here with us today. So I see you all tomorrow.
Yeah, thank you so much. This was really fun.
Thank you.
Less
Great
scary than
case,
I thought it would be. All right, see you guys.